Hi everyone, welcome to PNMI 101 Part 1. My name is Melissa Testa and I'm here with our PNMI consultant team.
Hi everyone, Amita Patel, one of the consultants on the team.
Hi folks, Katie Churchill.
Today, the first half of the training is going to cover random moment time study, treatment plan timeliness overview, and standards 1 through 24. The goal is to be able to understand all standards required for PNMI compliance and how to ensure that provided services are documented correctly. So PNMI stands for Private Non-Medical Institutions. PNMI is a federal Medicaid program that partially reimburses the Connecticut General Fund for state monies paid for out-of-home care in DCF therapeutic group homes and residential treatment centers with 16 or fewer beds. So our team conducts reviews, provides trainings, consultations, and technical assistance, and provides ongoing support to these programs. Reviews occur every 6 months for programs with less than 16 bed capacity and once a year for programs with greater than 16 licensed bed capacities. We also provide midterm reviews for any program who's underperforming only in programs with less than 16 bed capacities. We partner with DCF licensed programs to ensure that quality assurance of clinical and milieu rehab services are being provided to the youth. And we also do quality assurance for the random moment time study. What we would like to see is that the minimum requirement is that programs pass is 85% from random moment time study and a minimum of 74.5% for their PNMI review. Oh. Sorry, there we go. So random moment time study that we're looking for 85% compliance per quarter is required for programs. They're completed by all staff within PNMI programs who spend more than 20% of their time with their youth, and it's used to determine the rate billed to Medicaid for PNMI programs. What we're looking to do is to see the percent of time the staff spend doing reimbursable activities with the youth. The program RMTS liaison's responsibility are to enter the staff schedules by the 15th before the quarter begins, complete change of status requests as staff's roles change or they leave the program, or if they're on out for any medical needs or vacations, monitor staff's compliance of completing their random moments throughout the quarter, and then also just monitor making sure that the program's compliance is above 85%. If there's any technical questions or assistance needed, our partner program is in UMass, and here is the contact number for them, 1-800-535-6741. You can also email the DCF liaison for random moment time study, and the email address for that is dcf.pnmi@ct.gov.
Hi everyone. We are going to be using the sample packet throughout the rest of the training, and as we progress through the training, we will be referencing different pages to go along with the training. So for treatment plan timeliness overview, also known as the TPTO, we are going to be looking at page 7 and 8 in our sample packet. The TPTO allows us to review all treatment plans since our last review, and we're looking for all treatment plans to be authorized by the LCP for timeliness. The results you will get in the email of the TPTO will include results for your overall score, your initial treatment plans, your 30-day and your 90-day quarterly plans. The MTPPR planning tool and the treatment plan tracking tools can also be utilized to keep all your due dates for all the youth in your program on track. And again, we're only looking for LCP authorization for those treatment plans. So this is what the first page of the treatment plan timeliness overview report will look like that we will send you. This gives you your overall score, and it breaks down your score between your initial 30, your first 90-day and quarterly plans thereafter. This tool will be, it's an Excel instrument that we will send out again in the results email. For any blank spots, for example, on this one, the first 90 days blank, that's just indicating that you did not have any treatment plans that fell into that category during our treatment plan review period. The second page of this tool is actually what feeds all the information. Yep, there we go. So these scores are based on actually the information entered on page 2 of the tool. This and timeliness tool. Again, you can enter all of your youth, starting with their admission date, and this will keep you on track to authorize your treatment plans on time. The next one is the MTPPR tracking tool. Again, you can see that we put the youth's name in there, their admission date, and this will help you keep your treatment plans authorized on time, as well as your MTPPRs. Now this will be the second part of the report you'll get following a review conducted by the PNMI team. This is the weighted, unweighted report, and this will provide your overall record rating for the review, and it breaks the score down by category, both weighted and unweighted. Again, here we're looking for the overall results to be 74.5 under the weighted category, which will allow you to continue to stay in the reimbursable program list. So this is the PNMI exit sheet. We use this as a reference sheet during our exit meetings, and it's just a quick summary of all of our standards, and they are grouped by the different percentages. Those standards contribute to the overall score. And this is the third part of the report, which is actually the full report of the record review. And this will break down each standard we look at for the particular youth we review, and it will give you a C or an NA or an N for the standards that were compliant, not applicable, and not compliant during the review. This is the 35 standard packet that we have provided to you, and is also available on our DCF PNMI page. This is an in-depth explanation of each standard for PNMI.
So Amita just referenced for you the PNMI 35 standard packet, so you can follow right along, because at this point we're going to start really jumping into the meat of the training, which is talking about the different standards. And so the first section is the general information, and it's standards 1 through 7, and it's just worth 5%. So standard 1, full name. We need middle name. That's critical. First, middle, and last. We need to have that, and we need to have the legal name that is issued on the birth certificate. And so if you have a youth who's potentially going by a different name or a nickname or whatever that is, we need to make sure that at least on the face sheet that the full name, first, middle, and last legal name is listed there. out of respect for youth, if you want to put an AKA or document somewhere what the youth is going by, then you're more than welcome to do that, but you also need to have the full legal name. Standard 2, again, from the face sheet, is the child's sex, and again, this is the legal sex from birth. And again, if you want to respect individuals and put something addition onto your face sheet to put perhaps the gender or you know, how they want to be referred to, you are more than welcome to do that. Standard 3 is date of birth. Standard 4 is the link personal identification number. So not a case number. It's important that you have the individual youth personal identification number. Medical number, admission date. This is very important to make sure that you get accurate and make sure you have your admission date. And then actual discharge date. Some folks on their face sheet will put an anticipated discharge date, but upon discharge, that face sheet needs to be updated. Sometimes we will do a review of a closed record, and so we need to be able to go back and see that that face sheet has been updated for their actual discharge date. So this slide goes over standards 8 through 13, and this is really about our authorizations and evaluation documentation. So standard 8 is still speaking to the face sheet, and we need to have a reason for placement on the face sheet. So that needs to be kind of why they're not living at home, or why they're not in a less restricted setting, and why they're in your placement. It can go over whatever issues there were. That might be mental health issues, there may be medical issues, family situations, whatever that is. We're just looking for kind of a brief overview, just something quick to kind of explain to you why they're in your program. Standard 9 is going to be the psychosocial history. And this is going to be a freestanding document. It's going to be much more detailed than your face sheet. So the face sheet for the reason for placement is just going to be nice and quick. But the psychosocial history is really a well-documented, detailed report. That report needs to be done within 30 days of admission. And there's certain things, categories that need to be included there. And there's 3 that are clearly labeled that must be present. And that is a family history, a social history, and a medical health history. And so it's critical that those labels are exactly as they're stated here, and that you have all that information. In addition to that information, but it's not required to have a label for it, we need the developmental history and any psychiatric history. You know, we certainly find when we go out to programs that there's all sorts of different categories that you have, and you're welcome to, you know, make this document something that you want it to be, and you certainly capture the information that your program feels is important, but we also need to make sure that you capture these categories that we have set as well here in the standards. Standards 10, 11, and 12 all speak to the CANS registration. The CANS is a document that you're going to get from DCF, or you might get it from Beacon Health. So it's not a document that you're going to produce, but you're still required to have it in your record. So if you're not getting that from folks, you really need to, you know, make sure that you do obtain that. And so if you're struggling, then reach out to your next steps. If you can't get it from a social worker, go to the supervisor. Access Beacon, they're often able to help you with that. The CANS needs to have the level of care, the LCP signature, and the diagnosis. And having the CANS registration will make sure that you have the proper CANS, which has all that information. And so you'll see right on the top of the CANS in the left-hand corner, you'll see that it will say registration, and then you'll know that you have the proper CANS in your record. Standard 3 is all the authorizations and reauthorizations from Beacon Health. And so that really is a letter from Beacon saying that you have this youth in your program for a certain time period. And the first authorization is going to be the initial 1 through 49 days, and then thereafter it's going to be every 30 days. It's very important to make sure that this starts on the proper admission date. So if there's a problem with an admission date, you really need to address that right away and get that fixed through Beacon Health, so that you don't have that problem following you, and if a certain time period goes by, you're not going to be able to correct that. So it's critical that you see your first one comes in with the proper admission date. You'll often see that these authorizations will sometimes have overlapping. So one may end on January 12th and the next one starts on January 10th, and that's fine. What we can't have is one stopping on January 12th and the next one starting on January 14th. So we need to make sure that there's no gaps in the time period and that you have all that time covered on your authorizations. It's helpful when you get your authorization to look back at your previous one to make sure there's not a problem before you file that away in your records. So if there is, you can address that right away with Beacon and make sure that they correct that problem.
So the next set of standards we're going to talk about is standards 14 through 24, which compile 40% of your overall score. So the first standards are standards 14, 15, and 16, and they cover the initial plan, the 30-day plan, and the 90-day/quarterly plans. So what we're looking for these three standards is, are the plans there? Are they authorized? And are they authorized on time by an LCP? So what we mean is authorized. There needs to be an authorizing statement that says that the LCP is saying that this plan is valid and a start date. So we're looking for a dated signature, their credentials by the LCP, the printed name, their credentials again, and their agency title. And is it signed on time? So we're looking for the date again. So we have the treatment planning tracker tool that you can use to see the date these are due. So you can have the plan signed on time with the actual date, or you can have it signed with the effective date. So the dates can be signed up to 30 days prior to the due date. So if they sign it early, then they can say that it starts on that date, or they can say effective, and a lot of times it'll be the due date. And so you just need to make sure that you're very clear on the plan, whether it's the actual signature date or the effective date that we're utilizing for looking for services. So this is a copy of a sample treatment plan in the PNMI 101 sample packet, which is available on the DCF PNMI page. And so as you can see here with the red arrow, the LCP statement, and then it has the LCP's name, credentials, title, their signature, and their date. So who isn't an authorizing LCP? So this is a Connecticut statute, and it comes from the federal statute as well. And so only those listed here are eligible to be an LCP. The LPC is not on this list, and I know that gets confusing sometimes, but a licensed professional counselor is not an LCP. So the next standard we're going to look at is standard 17, and that talks about treatment planning participation. So beginning with the 30-day plan, we're looking to see that the plans are developed with the youth, the DCF worker, and the family representative. And how you document that is we're looking for all three signatures and the date that they participated in the plan development, and that a copy was provided to those participants. We're also looking for that there's a statement in there that the plan was presented to the youth in a language appropriate to their level of functioning. If for any reason that you're not able to get a signature, or that you're not able to get any of those, the youth or DCF or family representative to participate in the development of the plan, or you can't provide a copy, you want to make sure that there's a reason why you aren't able to do that. So there should be a space for an explanation as to why that those weren't able to be achieved. So as you can see in your sample packet, this is how a lot, and again, yours can look very differently. This is kind of just a sample that we provide, that we have the clinician statement here, that the treatment plan is presented in a language appropriate to the youth, the child's section with signatures, and that make sure that these check boxes get checked, that she participated in the planning meeting or attendance at the meeting, the DCF worker, the parent or parent representative, and then down here is that the section that a copy was provided, the date it was provided. We want to make sure that none of these are left blank. And so we also are looking for all of these to be completed by the date the LCP signs off on the plan. So if you're still working to get a DCF signature for some reason or a parent signature, then just put a reason in the plan as to why there's no signature, and you can obtain that at a later time. But we want to make sure that there are no blanks by the time the LCP signs off in the plan, so that you can able to achieve the standard. So treatment planning is the team approach. And so really what we want to know is that, are you engaging everyone in the treatment planning process? So we are looking for signatures from DCF, family representative, and youth, but we really want to see that you're engaging everyone in creating the treatment plan. And that includes Milieu staff, program directors, nursing, psychiatry. Some programs have them sign off on their plans and others do not. Other significant adults include mentors and placement resources. So we really want to make sure that everyone is involved in creating this plan for the youth to achieve the best outcomes.
Standard 18, sourcing the goals. So where did the information come from to create the goals? When, where, and who did the information come from for a diagnosis or a goal? So each goal needs to be linked to a source diagnosis and its associated symptoms. Requirements for sourcing the diagnosis are the date and the evaluator and/or a specific document. Each goal needs to be linked to a functional impairment and the comprehensive evaluation or assessment which identifies the youth's rehabilitation needs. Requirements for sourcing the functional impairment, the date and the document name. Sample packet, page 4, top right corner, gives an example of a source for this treatment plan, for the sample treatment plan, Dr. Pill's psychiatric evaluation, and the date of that. Standard 19, goals and objectives. So goals need to be clearly identified specific goals. A global statement that describes the improvement in the functional impairment. For example, the youth will utilize effective communication skills, the desired outcome or the youth's presentation when they achieve this goal. Goals can be an incremental or a small step toward achieving a larger goal. Ideally, it's to turn a current deficit upside down and write the opposite of the deficit as the desired outcome. Key words that are helpful in developing goals are exhibit, display, and demonstrate. Sample packet page 4 and 5 give examples of both good goals and objectives. An objective. An objective speaks of the work the youth will do to accomplish the goal. This is process-oriented. For example, the youth will learn or the youth will work on. Again, key words to help develop good objectives are learn, work, express, and explain. Objectives also do need to be measurable. Statements often included are as evidenced by or reduce, increase, or decrease in a certain behavior. The service description can be utilized on plans to describe strategies staff can use to teach particular skills to youth. And again, the sample packet has examples of objectives.
So Standard 20 speaks to the clinical and milieu services on the treatment plan. So you may refer to it as a service or an intervention within your program, whatever you call it, but we're speaking about the services that are provided to youth. And so that may be an individual therapy, a group therapy, milieu intervention, whatever label you have, and everybody's again is different. We need to see that that service is listed on your treatment plan. We also need to know who that service is going to be delivered by. And so that can include a title agency or a role. We recommend, rather than using a name, that you do go by an agency role, because if that person changes and you have a name, then you need to change your treatment plan, because if you have that name and that person isn't providing it, we're going to be looking for that person that is listed on the treatment plan. So you might say that the service is offered through the clinician, milieu staff, psychiatrist, whatever that is. We also need to see that those services are linked to a specific objective. And so we need to see that it's clearly connected to that objective. And so we have in our sample packet, again, page 4, you can see this here. So the first arrow on the left, down on the bottom, you'll see that points to the column of the objectives. And the very next one over is your service type. So the service type there is clearly linked to that objective. And that's the critical piece, that it's clearly linked there. On the right, you do see who the staff is that's going to be responsible for that service. And again, trying to avoid using a name is something that we do recommend. If your program insists on that, that's absolutely fine. You can do that. But just know, again, if that person changes, you're going to need to make adjustments for that. And so Standard 21 speaks to, again, clinical and milieu services. And this piece is about the frequency and duration. So every service needs to have a frequency and duration. So the frequency is how many times a week, a month, whatever, once a day, whatever that is. And the duration within minutes. So 60 minutes or an hour, 30 minutes, 15 minutes, whatever that is, you can put that in. A per service duration speaks to something that is time limited. So you might be starting your treatment plan, say, on February 1st, but you're going to have a group that's going to begin on March 1st. So you can write that clearly right into your duration, that it's starting on March 1st. So when we come in and we look at the treatment plan and then we begin to reference progress notes, we're able to say, okay, I'm going to expect to see those progress notes as of March 1st rather than February 1st when the treatment plan starts. There also is the opportunity for you to put a PRN, which is really an as needed, and that again is at the discretion of the clinician, and perhaps that might be a way, if something isn't offered consistently, that you're able to put that in, and so that you still see that. Frequency and duration always speaks to the minimum of what is expected. So you may say that individual therapy is going to be once a week for 60 minutes. You could offer that more, but we have to see minimally that frequency and duration is met. And again, here's from the sample packet, page 4, you'll be able to see here with the arrows, the duration and the frequency is listed. It's very clear on this treatment plan, and everybody has a different template, and so yours might not look exactly like this, but it's very clear that you can see the objective, the service type, the description, the duration, the frequency, who is providing it. It's all right there, very clearly connected. I will say that I've seen in the past that sometimes you might see an objective on one part of a treatment plan, but later in the treatment plan, you may reference then the service type and the duration and frequency there. And whatever system you come up with is fine, as long as we can see that it's clearly linked. And the caution that we just say is sometimes when it's on a different page or somewhere else in your plan, sometimes we see that possibility of not linking it clearly. Maybe you're supposed to write 1A, but you write 1B. So just caution you to make sure that it's linked very well and we see that very clearly. This here is from page 5 of the sample packet, and this really speaks to Milieu services. Sometimes we will see Milieu services offered. Maybe there's 2 topics. So maybe you have one that's talking about emotional regulation, and you have another one that's talking about life skills. And what we're saying here is that you can list those 2 different things and still put that it's going to be offered 15 minutes on a daily basis. And as long as one of those are covered, 15 minutes on a daily basis, you're going to be fine with that. We've had some programs that will do that, and then they'll say one is going to be offered on a Monday, Wednesday, and Friday, and the other on Tuesday, Thursday, Saturday, Sunday. And so sometimes that, again, here's the caution that we see where a Milieu staff may not deliver it on the day that you were supposed to. And that's going to be a problem when we come in and do our review, because we're looking for the exact thing that you write down in your treatment plan. So this is a nice way, if you're going to cover different topics, for you to see that you can just write 15 minutes on a daily basis, and no matter when that's delivered, you're going to be spot on and you're going to be fine with your PNMI review. So outside clinical services, occasionally we will see that a youth is going to an outside provider for maybe a specific issue that you are not providing within the program. And so if you put that in your treatment plan, then we must see progress notes that, that coincide with that. And so you always have to comply with the standards 20 and 21 that we just talked about. And so some folks may find that challenging sometimes to obtain that, but we have a great workaround for you, and you're going to be able to still document what you need by looking at either the outside provider to do that. Again, if they don't do that, then you can do that. You may be able to connect with the DCF worker. Let's say they're bringing the youth to the service, then you're going to be able to obtain that information from them. Or if you need to, you can get that information from the youth themselves. But that's the workaround. So if you put that in your treatment plan, then you need to have that in your progress notes as well. So treatment plan addendums, and this is important to talk about because if there's any kind of changes, so you know, if it's a 90-day period that you're working with this youth on your goals and objectives and the services that you're working on, if there's any kind of changes, there needs to be an update to that. And so we need to be able to see that, and it may be that the clinician is feeling like, okay, you know, I was going down this path, but the youth is really struggling and I've got to do something a little bit different to help engage them in a different, more effective way. And so we need to see that change through an addendum. And so we need an effective end or start date for any goal, objective, or service that you're making a change to. We need to make sure that the LCP authorizes that and that there's a signature on the addendum. We need to make sure that the youth is engaged in that process so that they understand what's being changed within their plan and what's being expected of them as far as their treatment. We don't have to have all the other signatures that you've seen in Standard 17, but we do need to make sure that you provide a copy to DCF and the parent as well so that everybody is in that loop and everybody knows what's going on. Prior to this, you heard me speak about a time-limited service. And the time-limited service may be a way to avoid an addendum. So again, that scenario I used, that a treatment plan was starting in February, but a group wasn't happening until March. That's a great way to kind of document that information, and then you don't have to do an addendum. If you don't put that information in about the group starting in March, then we need to see an addendum in March when that group does start up. So either way, you can kind of attack that either by doing the addendum or writing the time-limited services. But if things just change abruptly in the middle of the plan, or you're working it for a little while and you feel like, okay, I've got to do something different, then we absolutely need to see an addendum to that.
So the next standard we're talking about is Standard 22, reauthorizations of treatment plans. So beginning with the 90-day plan, each treatment plan must be authorized by the LCP. So these can be signed up to 31 days in advance, but they have to be signed by the due date. They cannot be 1 day late. Again, you can sign them 31 days early, but they cannot be 1 day late. Standard 23 talks about a detailed progress review. And so beginning with the 90-day plan, we're looking for a detailed progress statement for each individual goal and each individual objective. So every goal and every objective within your plan has to have a progress statement. They can be in a separate document, but that document has to be signed and authorized by the LCP. But they can be, and most typically we see them within your treatment plan. In your sample packet, here is an example of, for the goal, a progress statement, and also for the objectives, progress statements.
All right, Standard 24, beginning with the 30-day treatment plan, discharge planning must be documented to include the 6 following elements. What is the discharge plan for the youth? Is it reunification, independent living? And here we're looking for your agency's discharge plan for the youth. Often we hear that programs don't know what the plan is from DCF. Again, we're looking for what is your agency's clinical recommendation for the youth's discharge plan. We're looking for a full projected discharge date, a discharge caregiver. So here we're looking for an actual person, not an agency. Here we can accept DDS staff, for example, rather than just DDS. We're looking for a concurrent discharge plan if it's applicable. What services the youth will need post-discharge. Here, again, it's important to know what services the youth will need. Even if you don't know the geographical area the youth will discharge to, what will they need? Will they need to continue individual counseling? Will they need to continue medication management services? So just what their services will be post-discharge. And are there any barriers to discharge? If there are barriers, we're also looking for the steps to address those barriers. In the sample packet, we have an example of the discharge plan on page 5. Here we're looking at a discharge plan for Johnny, which is reunification with his father with a projected discharge date of October 1st, 2019. Services he will need are listed, and there are no barriers identified and no concurrent planning needed for Johnny.
So folks, that ends part 1 of this training. You'll see a nice link listed right here where you can find all of the resources that we talked about, and you can reference those at any time. There is a part 2. We want to make sure that you do a follow-up with that. The information is not the same at all. We're going to go over the rest of the standards, so you're going to want to make sure you absolutely do catch that part 2. We want to encourage you to reach out to our team here. We're here for you for support. This is a team process, and we're more than happy to work with you. So reach out to your assigned PNMI consultant. And I think that's it. Thank you so much.